This is A&P Live Studio, and I am your host. I teach A&P as a registered nurse and anatomy and physiology instructor for advanced level healthcare pros. Today, we're going to explore the really complex syndrome of heart failure, and we'll be guided by the latest clinical guidelines from the major cardiology organizations out there.
So let's start with a clinical scenario, one you'll almost certainly encounter. Let's meet James. He's 55 years old, and he's come in because, well, he just doesn't feel right. He's been feeling incredibly tired, and even simple things are leaving him completely out of breath.
And when we dig a little deeper, his symptoms really start to paint a classic picture. He has worsening shortness of breath, what we call dyspnea. There's swelling in his ankles, that peripheral edema. He's dealing with this deep, profound fatigue. And then there's the telltale sign. He has to prop himself up with a bunch of pillows just to breathe at night. That's autopnea. Now, it's really important to note that data shows Black individuals face the highest risk for developing heart failure. So James's story isn't just a textbook case, it's a clinically vital one for us to understand.
Okay, so all of James's symptoms are basically waving a huge red flag that his heart is struggling. To really get what's happening, we need a good roadmap. We're going to start right where we are with James's story. Then we'll back up and look at how a healthy heart is supposed to work before we dive into what happens when that pump fails. From there, we'll connect all those dots to the clinical signs, look at how we can fix it, and finally, wrap it all up by seeing why heart failure isn't just about the heart, it's a whole body issue.
Right, so before we can really wrap our heads around what's going wrong, we have to appreciate what's supposed to go right. And honestly, the healthy heart is nothing short of an engineering marvel.
Just think about this. Every single minute of every single day, it pumps about 1.5 gallons of blood through your body. It's just relentless. And all of that incredible work is made possible by this elegant, precise stance at the cellular level called excitation-contraction coupling.
All that fancy term means is that an electrical spark tells a heart muscle cell to release a flood of calcium. And that calcium, it's like the key in an ignition. It turns on the machinery, our actin and myosin filaments, allowing them to grab on and pull, creating that powerful, coordinated squeeze. So what happens when this perfect system starts to fall apart?
Well, heart failure almost never just appears out of the blue. It's usually the final stop on a long road of damage that's been happening for years. Things like coronary artery disease, years of untreated high blood pressure, faulty valves, these are the usual suspects. Now here's the crazy part. After that first injury, the body, in its wisdom, tries to compensate, but the very things it does to help in the short term end up becoming the problem, kicking off this vicious downward spiral. Okay, so picture this. It starts with some kind of insult, maybe a heart attack that weakens the pump. Cardiac output drops. The body panics and hits the big red alarm buttons, activating the sympathetic nervous system and the RAS system. This cranks up heart rate and blood pressure to try and keep blood flowing. But when those alarms stay on for months or years, they become destructive. They cause the heart muscle to get thick, scarred, and stiff in a process we call maladaptive remodeling. And that just makes the pump work even worse. Now let's zoom in way down into James's heart cells. All that systemic stress has a direct impact on that calcium machinery we just talked about. The sarcoplasmic reticulum, which is supposed to store and release calcium, starts to fail. Specifically, a little pump called circuit 2A, which is responsible for sucking calcium back up after each beat, gets lazy. This creates a double whammy. There's not enough calcium for a good, strong squeeze, and the muscle can't fully relax afterward because the old calcium is still hanging around. And right there, that failure at the cellular level is the direct cause of the symptoms James is feeling. Every single thing he's experiencing tells a piece of this physiological story.
So his shortness of breath, that's a classic sign of backward failure. The left side of his heart can't pump blood forward, so it backs up, right into his lungs. The swelling in his ankles? That's the RAS system telling his kidneys to hold on to salt and water, which is made worse if the right side of the heart is failing too. And that crushing fatigue? That's forward failure. The heart just isn't pumping enough oxygen-rich blood out to his muscles and organs.
So during our exam, we're looking for clues to confirm all this. We checked for an elevated jugular venous pressure, which tells us pressures are high on the right side of the heart. We listened to his lungs for crackles, which is literally the sound of fluid in the small airways. We might hear an extra heart sound, an S3 gallop, which is the sound of blood sloshing into a stiff, overfilled ventricle. Even something like bendopnea, getting short of breath when he bends over, tells us those filling pressures are way too high.
But to really seal the diagnosis, we turn to the lab. And the absolute cornerstone is a blood test for something called natriuretic peptides, or NT-proBNP.
You see, when the heart muscle gets stretched and strained, it cries for help by releasing these hormones. They're a signal to the body to get rid of fluid. So when we see high levels, it's a very, very specific sign that the heart is under serious distress. Okay, so now we move from diagnosis to what we can actually do about it. And for heart failure with a reduced ejection fraction, which is what James likely has, our treatment strategy is built on what we call the 4 pillars of therapy.
And this is just beautiful because these 4 drug classes directly counter the very problems we just talked about. We have medications to block that runaway ROS system. We have beta blockers to calm down the overactive sympathetic nervous system. We use MRAs to specifically block a nasty hormone called aldosterone. And we have the newer SGLT2 inhibitors, which have these amazing protective effects on both the heart and the kidneys.
Let's just take beta blockers as an example. By blocking the effects of adrenaline, they basically tell the overworked heart that it can take a breath. It doesn't have to sprint 24/7. This doesn't just slow the heart rate down. It actually shields the heart cells from the toxic effects of being in that constant state of panic, which can halt and sometimes even reverse that negative remodeling. And this is the really key takeaway. These drugs don't just put a Band-Aid on the symptoms. They go right to the root of the problem. They target the maladaptive processes that are driving the disease. You can see this with ACE inhibitors and MRAs. They both go after the RAS system, but from different angles. One stops a powerful blood vessel constrictor from being made, and the other blocks the hormone at the very end of the chain that causes fluid retention and scarring. It's a multi-pronged attack.
By hitting the problem from all these different angles, we can really start to change the course of the disease for patients like James. And that's so critical because, as we've been hinting at, heart failure isn't just a heart problem. It is a systemic syndrome that drags the whole body down with it.
The kidneys get less blood flow, which ironically makes them scream for the RAS system to turn on even more. The lungs, as we know, get congested. The muscles can start to waste away because they aren't getting enough oxygen, which makes the fatigue even worse. The nervous and endocrine systems are just stuck in overdrive. It's this web of dysfunction that shows us why we have to treat this holistically.
So let's just recap that whole journey. We start with a perfectly normal heart doing its job. Then an injury kicks off a damaging neurohormonal cascade that messes things up at the cellular level. That cellular mess shows up as the clinical symptoms we see in our patient James. In our treatment, it's aimed squarely at shutting down that very cascade to stop the disease in its tracks. Understanding that entire pathway, from start to finish, is absolutely key to providing great care.
I want to leave you with this quote from Dr. Arnold Katz, who is a true giant in cardiology. I think it's just a beautiful reminder that truly understanding the elegance of normal physiology is the only way we can ever hope to master pathophysiology.
And that wraps up our look into heart failure. Just remember, all of this is for educational purposes and should never replace the advice of a healthcare professional. Stay pathocurious, and I'll see you in the next episode.